Well, thanks for coming. My name is Janell Jones. I'm a PT at Craig Hospital. At Craig in Colorado, we see brain injury and spinal cord injury exclusively. We have an inpatient side and an outpatient side. And I started inpatient in both spinal cord injury and brain injury. And then I've been in the outpatient spinal cord injury department for the last, I think we've decided 6 or 7 years. So that's me. And this is Maggie.
Yeah, and I'm Maggie, also a physical therapist at Craig Hospital in Colorado. And similar to Janell, worked both inpatient and outpatient. I started in the outpatient realm and then have been back in that realm for about the last 6 years, working with patients with spinal cord injury.
So today we're going to talk to you about wheelchair backs that support the spinal curves, assessing backrest type and placement with postural and functional outcomes. Okay, and we have no conflicts to disclose. Thing. Okay, so a little bit about what brought us to the present study. So I think we can all agree that a properly fit wheelchair and seating system can have a profound effect on the lives of individuals living with spinal cord injury. Part of the seating system, in addition to the cushion, is the backrest. And a backrest that can support the natural spinal curves is thought to enhance posture, improve function and mobility, and improve comfort for manual wheelchair users. However, there's little research actually comparing the efficacy of a solid posture back, so an aftermarket back, to the upholstery back that might come standard on a wheelchair. So several years ago, this was brought up by some payer sources of saying, hey, why should we pay for these aftermarket backs? The back comes on the wheelchair, you get one free. And is this really better? And we said, well, yeah, it's better. They said, well, where's your evidence? We said, well, do you want to fund the study? And they said, no. So that spurred us to conduct a pilot study a few years ago. And in the pilot study, it demonstrated clinical relevance and statistical trends of improvements in posture, improvements in function when using a solid back over the upholstery back. But again, pilot study was a small number, high variability, so we didn't quite have enough power to establish that statistical significance. Nevertheless, as you can see in this teeny tiny little upper left-hand corner there, it was published. The results of that pilot study were published in the Journal of Spinal Cord Medicine last year in 2022. So you can find that to find out more about it. But that brings us here.
Yeah, so that brings us to objectives of a current study that we're conducting. So we're going to kind of in this presentation go over some of the information from our initial pilot study, as well as kind of how we're progressing that. So our in-progress study, we have 2 main objectives. One is to perform a fully powered analysis of the difference of that upholstered backrest in comparison to a solid backrest. And since we're bringing a large number of individuals for that fully powered study back into our clinic, that we are also evaluating type of backrest and the position of that backrest and what types of impacts that has on postural measurements, on functional outcome, patient satisfaction, et cetera. The presentation today, we want to define backrests, so kind of the categorize of backrests, as well as the positioning terminology that we're using, and then to describe how we're evaluating backrest placement and discuss the postural, functional, physiological, and subjective outcomes that are used in our current study that's ongoing, as well as something that can, I think, be applied in the clinic when looking at backrest prescription. For the current study, we are looking at including 150 participants. This is a multi-site study, so Craig Hospital is involved, as well as Kessler and Shirley Ryan Ability Lab. Individuals enrolled in this study have motor complete injuries. They are full-time manual wheelchair users, and their injuries are from the level of C6 to T4. So not having any abdominal activation, that core activation. So we're really looking at the backrest specifically. Going into our terminology, So we are defining an active contour backrest versus a deep contour backrest. So that active contour being less than 3 inches of contour, deep contour being greater than 5 inches. And for the current study that we're using 2 different manufacturers that both fall within those categories for both that active contour as well as that deep contour backrest. So that kind of describes what the shape of the backrest that we're evaluating is. And then next, we're looking at the position of that backrest and comparing with seat gap and without seat gap. So with seat gap, we're defining that as the bottom of the shell is enveloping PSISs. Without seat gap, that backrest is lowered to less than or equal to 1 inch above the seat cushion. And then we're looking at the upper height of that backrest, looking to see if scapulas are free, so the backrest being 1 inch below inferior angle, or if the scapula is blocked with the backrest being mounted 1 inch above. In this study, we're looking at a comparison of like 5 different configurations. So as we mentioned from the pilot study, the first one is looking at an upholstered backrest. So ideally, this is mounted 1 inch above the inferior angle. Really, it's limited by what the back cane height is and simulating that posterior pelvic tilt in what would be a on-the-chair upholstered backrest. Next, we're comparing that to an active contour solid backrest, and this is mounted with seat gap and free scap. So PSIS and then 1 inch below inferior angle. And so that kind of gives us that first comparison of upholstered versus that solid backrest. And then we go into a little bit more of what implications backrest placement has. Our third backrest is an active contour backrest again. And this time instead, we are mounting it 1 inch above the inferior angle of the scapula so that scapula is blocked. And then we'll look at the functional and postural implications of that in comparison to when it's below the scapula. Our next configuration is a deep contoured backrest. This is mounted again with seat gap and below the level of the scapula. And we'll be looking at the difference of that in comparison. So deep backrest in comparison to that active contour backrest. And our last configuration is a deep contour backrest that is mounted without seat gap. So comparing the effective seat gap in the contoured backrest. So with seat gap and without seat gap in that deep contour backrest.
Okay. So those were all the things that we're studying. And so how are we going to evaluate them? So we have several postural outcomes. We have 6. One is pelvic angle. So measuring the angle between the femur and the pelvis. And this is really to get a sense of, are they in a neutral pelvis? Do they lean toward anterior tilt or posterior tilt? We're also looking at spinal angle of kyphosis. So instead of measuring femur to pelvis, we're measuring femur to acromion. So are they in relative trunk flexion or are they arching over and they're in trunk extension? And then in the frontal plane, that frontal pelvic angle, so a line between as is to as is with reference to the horizontal to get an idea of pelvic obliquity. I've just combined all the words into one. We're zooming through. And then correspondingly, that frontal sternal angle. So trying to get a measure of scoliosis. So the sternum with reference to the vertical. Then we're also doing a linear measurement of the spine, just going floor to acromion to see if any of the backrest wheelchair configurations that we have, is that just changing their overall seat to floor height? And does that have any correlation with their function or not? And then lastly, the back angle. So just measuring the angle of the solid back with reference to the ground. So do they need to be in a more closed position, a more open, upright, looking at that. Those are the postural outcomes. For the functional outcomes, we're looking at 4 functional outcomes. So the first is that vertical forward reach test. So you're seeing she's reaching in front of her and then up. And so we're trying to get a measure of how high you can reach going in front first. So really a measure of postural stability. So we have someone behind spotting. There's a level on the yardstick. We have, it's very high tech. We have Vel foam that is taped around. So if they don't have grip, they can stick their hands in there and still grasp on. And there's a level taped. And so they come up and we make sure it's level, and they can mark on that page the height of that. And so we do that in each back. If they were to lose their balance, let's say forward, we have the spotter, we can stop them there and then mark the height at which they lost their balance. And that would be the height they would reach. Then there's the one stroke push test. So this is just measures the distance the wheelchair travels with one push over carpet. Timed forward wheeling is measuring the time it takes them to traverse a 23-meter level indoor surface path in the forward direction. And then the same thing with ramp ascent in the forward direction going up a ramp. It's a 10-meter ramp with a 1 to 12 slope. So a 5-degree, 10-meter ramp, and measuring the time that it takes them to go up that ramp. Those were the functional outcomes. We're also doing some physiologic outcomes. So we're looking at spirometry, rate of perceived exertion, change in heart rate, and O2 sat before and after the 23-meter push test. For spirometry, in case it's been a while since you've done POEM. So we're looking at FVC, so forced vital capacity, which is the largest amount of air that you can forcefully exhale after maximally inhaling. So it's a deep breath, close around the device, blow out real fast for what seems like a really long time when you're measuring it, and then measure that capacity. FEV1, forced expiratory volume in the first second, is again, how much of that air after maximal inspiration, how much can you blow out in that first second of that full blowout? Normally, it's at least 80% of forced vital capacity. PEF, peak expiratory flow. So you can see that's that slope there. Peak expiratory flow rate, the maximum speed of air when exhaling. And that normally ranges between 400 and 700 liters per minute. So there's some references we have. And then last but not least, we can calculate the ratio of FEV1 to forced vital capacity. So FEV over FVC. And that ratio represents the percent of your lung capacity that can be exhaled in 1 second. In the absence of any kind of restricted lung disease that might abnormally inflate that value, the higher the ratio implies healthier or more optimal lung function. So just looking, does the posture that you're in impact your ability to breathe is basically what that boils down to. And a couple subjective outcomes, the infamous pain rating, which everyone knows and loves. Oh my goodness, we're skipping way ahead. Here we go. Pain ratings, and then a satisfaction survey. So both of these things are done when they're, we ask about pain before they get in each backrest configuration, and then they go through the postural measurements, functional outcomes, and then we ask about pain at the end of those measurements. And then they fill out a survey that asks questions like, would you use this backrest on a daily basis? Would it make tasks harder or easier? Those sorts of things. And those are the outcomes. So as we said, the study is in progress. We want to do 150 participants. To date, we've completed 35 of the 150. And we're hoping to finish all 150 in the next year to year and a half, because again, we're looking at, it's a three-site study. So hopefully that goal is met. Any questions for us about anything?
I would just ask, like, I wonder if what's the comparison to their current status, whatever they have, and then things are different.
Yeah. And we are noting, so we have like demographic information, which includes their existing wheelchair, backrest, and cushion type. And so I think with the number of participants that we're having in this, we are looking to like stratify maybe based on level of injury, or if somebody was already coming in a deeper contour back, do their outcomes vary based on, or in comparison to somebody who's in an active contour backrest? So that's definitely something that we're interested in.
And they're using their own, if we've said this, but they're using their own chair. So we're mounting each back on their chair so that the chair should already be set up in a way that works for them and fits them and all of that. So we're not trying to like monkey around with all that. We're just doing the backrest on and off their own personal chair.
Do you do all in one sitting? The person?
We have been, so the protocol's written that we can complete it within a 2 setting period, but so far we've completed them all within 1. They're given rest breaks as needed and
Usually they can rest while we're like fitting the next back or taking the posture measurements. They don't really have to do anything. So that's usually, so far, we haven't had to give anyone additional rest beyond that. But it's built in that we can.
You mentioned 2 brands. Did you try both of those brands with each person, or did you just go with a mild contour back to the motion concepts? And
Yeah, we have active contours and deep contours in both. We just, because we didn't want to limit the study to the size of the person. And so some backs can get taller than others and some can get shorter than others. So it's really based on the size of back that we need. So some, I think, is it 8 inches?
Mhm.
8-inch tall up to like 14 inches tall, and then 12 inches up to 16 inches. So it's really based on more than
from either
the height.
back, you just kind of said, I need an 8-inch back. You had one motion, you used it versus.
Yeah.
so individuals with a shorter trunk length are using a motion back. Thank you.
Thank you.